Hey guys, and welcome to the Airway and Respiratory Anatomy part of the lecture for the paramedic refresher class. I'm going to take just a few slides to go over and discuss some of the stuff that tends to get lost as you advance through your careers. And so we're just going to refresh that a little bit. So remember that the functions of the respiratory system is to provide a large area for gas exchange between air and blood, right? It's going to move air to and from gas exchange surfaces. It's going to protect the respiratory surfaces from dehydration, temperature, and invading pathogens. Produces sounds for us to communicate, and then olfactory sensations for the central nervous system. Okay, so real quick, just a good review over the upper airway anatomy. So first we have the nose, right? We have the entrance or the nair, and as you see, we have the nasal vestibule, which is a space enclosed within that kind of flexible tissue of the nose, and that's where those little cilia or those coarse hairs extend across the nostril. So that's where a lot of the big particles are captured in that nasal cavity. So in the nasal cavity, right, there's two walls. There's three. There's the lateral, there's that medial septal wall, and then the superior wall. Right? And then you have your maxillary nasal frontal ethmoid and sphenoid bones, right, kind of all up in this area, kind of right up on the sphenoids are kind of here, right, and then you've got that frontal bone up here, and so on and so forth. So once we get past the nasal cavity, right, we've got that nasal vestibule, which it's that space inside that's enclosed within that flexible tissue of the nose. Okay, and again, that's gonna protect all the nasal cavity from those large airborne particles. And then on the floor of the nasal cavity is the palatine bone and the maxillary bones, right? So you got the palatine bone, and then you've got the maxillary or those cheekbones. Okay. So you've got the nasopharynx, and part of the nasopharynx, or what kind of makes up that nasopharynx, is the nasal conchae, the respiratory mucosa, and then mucus itself. So those nasal conchae or those turbinates, right, help with airflow that it projects up towards the septum from the walls of the nasal cavity, and that's where that promotes filtration in between those three conchae. And then if you look at as you're looking at that diagram, you'll notice that there's kind of clear three nasal conchae, and the lining of that cavity is going to be located with mucus. Okay, and between the mucus and then the turbinates, or the shaping of the conchae, right, creates some turbulent airflow, and that turbulence helps to provide warming and humidification of air coming in to the nasal cavity, into the nasopharynx. And remember that nasopharynx, on the superior border of it, is where the kind of the brain case sits. So we're kind of warming air for a variety of reasons, one of which is you don't want a bunch of cool air moving in underneath your melon. Okay, so so as we talk about, or as we kind of delve, as we go talking about the bigger structures of airway anatomy, right, we break them up, and the ones we mostly concern ourselves with is the pharynx, which we're going to break up into three categories. We've previously talked about the nasopharynx, Then we have the oropharynx and then the laryngopharynx. So the nasopharynx, right? We just talked about that. You've got the external and internal nares, right? Extends to the posterior edge of the soft palate. So from the nare to where that soft palate meets in the posterior portion of the nasal cavity and that posterior superior portion of the oral cavity. It's lined with that respiratory epithelium and also that pharyngeal tonsil, and the entrances to the auditory tubes are also located there. In the oropharynx, okay, so on the superior border of it, that's where the soft palate is, and it's going to continue inferiorly, to the base of the tongue, right about the level, or right at the level of that hyoid bone, okay? And that's going to, and in the oropharynx, we're going to have the palatine tonsils, and it's going to be lined with that stratified squamous epithelium. And then inferior to the oropharynx is going to be the laryngopharynx. So that's that narrow passageway. So on the superior border or aspect of it, you're going to have it's going to extend from the level of the hyoid bone, inferior, and it's going to end at the entrance to that leaf-shaped structure we have come to call not the leaf-shaped structure, but we're going to talk about the food pipe, right? It extends to the food pipe or to the esophagus, right? So it extends a little bit past the epiglottis. Okay, and it's also lined with stratified squamous epithelium. Okay. As we look at the larynx, we also call the larynx the voice box, right? No big shocker there for most of you guys. There are 3 cartilages. Right, there's the epiglottis, the thyroid cartilage, and the cricoid cartilage. For most of us, we're pretty familiar with that epiglottis and that thyroid cartilage, but maybe not so much. That cricoid cartilage, but not so much that thyroid cartilage, right? Even though the thyroid cartilage, you would find that that's what most people end up using for the cric pressure. And so actually it ends up being a better landmark, but it isn't truly the cricoid pressure or the cric cartilage that we're pushing down on. And just as a side note, remember that cric pressure's pretty much been taken out of airway management, at least from the ACLS perspective. Back to before, right? We've got the voice box. It begins at the glottis, or that glottic opening, right? It consists of 9 cartilages. It's stabilized by ligaments and skeletal muscle. Then we get to that epiglottis, right? It's that shoehorn or leaf-shaped structure. It protects that glottic opening. And then it folds over the glottis during swallowing. So basically we don't want to choke ourselves. So if you, as you look at the diagram, right? So we've got our epiglottis here, right? The vocal cords, and that epiglottis is going to, as the vocal cord shut, right, is going to flop over and kind of cover this so that we end up not choking. Okay, so yeah, again, so as we talk about the cartilages, right, again, that thyroid cartilage is the one we typically use for the cric pressure, I think. Yeah, so we're erroneously using that term. It forms the anterior and lateral surfaces of the larynx. That prominent little bit is called the Adam's apple, and it's superior to that cricoid cartilage. So it's the more it flares and widens at the superior aspects of it. It protects the glottis and the entrance to the trachea, and it provides the attachments for laryngeal muscles and ligaments. So just superior to or inferior to that thyroid cartilage is going to be that cricoid cartilage. It's going to provide posterior support to the larynx, protects the glottis and the entrance to the trachea, and it too is going to provide attachments for the laryngeal muscles of the ligaments, laryngeal muscles and ligaments. As you see, the larynx is also, there contains 3 pairs of smaller cartilages. you've got that arytenoid cartilage. And as we start talking about the arytenoid cartilage, um, these are some of the structures that, as we start taking an even more systematic approach to intubation and visualization, these the arytenoids here, um, the epiglottis, right? These all become more and more important in really non-traumatic, good systematic intubation. So the pharynx is going to separate the mouth and nose from the larynx and the esophagus, and air is going to move through the pharynx, right? That's like a no-brainer, and that's atmospheric air through the upper airway. Okay, the larynx, the voice box, is going to contain to the top of the trachea. Again, just some review from before. Thyroid cartilage, Adam's apple, cricoid, and then that epiglottis covers that tracheal opening. Okay, so once we go, as we're going down or from superior to inferior, we talk about the trachea. It's that tough, flexible tube. It's robust, but doesn't take a lot of, like, you can't grab it and shake it like like a kung fu movie and like ripping out somebody's stuff, right? So the diameter's 2.5 centimeters, length's about 11 centimeters, and so it begins at the level of cervical 6 and attaches to that cricoid cartilage. Okay, so there's kind of this clear delineation that you see here. So we've got the larynx, right, and then the trachea proper. Okay, so there's actual delineation, right, and you got your little hyoid bone there, right, and then you've got, some dots and a smiley face. Yeah, that's pretty unnecessary. Anyway, so the trachea is going to end about the level of T5 in the mediastinum, right there, kind of in that carinal area, right? Let's go back one. So in that, kind of right there in the carinal, right there, right, and it's going to branch into that right and left stem, or right and left stem, what we tend to call bronchi, or the right and left primary bronchi. And you'll notice, right, that the right is just a little bit straighter than the left. Okay. The walls are supported by about 15 or 20 cartilaginous C-shaped rings, and that open end of that C faces towards the esophagus, and that's going to allow that food to pass through the esophagus. Protects the airway. Those cartilaginous rings stiffen the tracheal walls and prevent that overexpansion and collapse, right? Because we're talking about atmospheric pressures, and quite a bit of pressure actually in terms of air moving to and from the outside environment to the internal environment and vice versa. It connects by an elastic ligament in the trachealis muscle, smooth muscle, and that's going to adjust the diameter of the trachea. That's an autonomic control thing. And so it's no big surprise, I think, that sympathetic nervous system stimulation is going to increase the diameter, right? Because we want more air in response to whatever has elicited that response. Okay, so as air moves to the trachea from the pharynx, right? We've got that division of upper and lower airway. Then we start moving down the trachea, and we've kind of previously talked about the primary bronchi, the right and left, which divide at the carina, right? That one point where we have the bifurcation of the bronchi. Then we move down to the secondary bronchi, the tertiary bronchi, the bronchi cartilage. Then we're going to just talk about the bronchioles, lobes of the lungs, the terminals, and the terminal bronchioles, the alveolar ducts, and the alveoli. So that system, right, the bronchioles are under sympathetic activation. They relax the smooth muscle. It causes some bronchodilation. And then in that organization of the respiratory system, the bronchioles can have parasympathetic activation, contraction of smooth muscles, some bronchoconstriction, and that bronchoconstriction can also cause, in extreme cases, complete blockage of the airways. And so an example of that would be like a severe asthma attack or allergic reaction. So then, continuing on with that anatomy of the lower respiratory system, we've got the alveoli. It exchanges, it's the exchange surface of the lung. It's about 150 million in each lung, and it gives that lung that spongy appearance. It's covered with that surfactant, those alveoli. It's kind of an oily substance. Kind of covers that alveolar surface, and it's going to reduce the surface tension, so to help the alveoli maintain their shape and prevent it from collapsing. And a lot of time, respiratory distress syndrome, is due or is characterized by inadequate surfactant, and it can be a result a lot of times from injury or even genetic abnormality. And so when you inhale, it must be forceful enough to open that alveoli. And so, these folks a lot of times, for whatever reason, whether it's bronchitis or emphysema, which are not exactly surfactant, necessarily surfactant related, but that we're trying to constantly splint those alveoli or those alveolar sacs open so that we can have good gaseous exchange. Continuing on, right, we've got the lungs. So you've got the apex, which is at the top. Shocker. They're blunt and round. It extends into the base of the neck above the first rib, which would be just below your clavicle or your collarbone. And the base, as you can see, gets concaved, and it rests kind of on that superior surface of the diaphragm, right? And that diaphragm is vitally important in the normal ventilatory process for people. Okay, so the lungs, you got that costal surface, follows the interior content of the rib cage, and then that medial sternal surface, grooves that kind of mark the passage of the large blood vessels. It has an indentation for the pericardium and that cardiac notch. Okay, so this is sort of a looking down view, right? We've taken that superior view, and now we're kind of slicing horizontally. Okay, so each lung occupies a pleural cavity inside of that thoracic cavity. Okay, and then they're separated by the mediastinum, and it's lined by the pleural, right, which is a serous membrane. It's got fluid in that membrane, which decreases the the impact of friction, and increases the lubricate. It tends to lubricate it so that we have easier expansion of the lungs. Pleural cavities, right? You've got the parietal. It's that inner surface of the wall. Body wall goes over the diaphragm and the mediastinum. Then you've got that visceral pleura that covers the outer surface of the lung and extends into the fissures. And that pleural space is usually in close contact, and it has that pleural fluid, which I previously spoke about. So continuing even, going even more inferior, we have the diaphragm. It's that thin dome-shaped muscle separates the thoracic cavity from the abdominal cavity. It's made up of skeletal muscle. It can be both voluntary and involuntary, or under voluntary and involuntary control. Voluntary is that breath, cough, holding your breath. Involuntary is sleeping or just kind of daily breathing. So in the respiratory process, right, inhalation, that diaphragm is going to flatten out, the intercostal muscles are going to contract, and it's going to increase the potential, it's going to increase the available volume inside the thoracic cavity, which will allow the lungs to expand, and then atmospheric air is going to come in through either the nose, either the naso or oropharynxes, and following the pressure gradient from greater to lesser is going to force air into the lungs. So in terms of importance, the diaphragm is going to account for 75% of air movement, while the external intercostals are only about 25%. Okay, so that diaphragm is super important in both ventilation and ultimately respiration. Okay, so if inhalation was an active process, exhalation is going to be a passive process. So it's going to be a relaxation. The thoracic cavity is going to recoil. Okay, the lung volume decreases, and so air is going to again follow that pressure gradient. As the pressure increases inside the thoracic cavity, it's going to force air out the naso or oropharynx, or both, and air is then expired into the atmosphere. Lung volumes and capacities, the total volume or tidal volume of air inside an average lung that moves into or out of the lungs in a single cycle is about 500 milliliters or half a liter. It's a pretty small amount of air is exchanged. And the volume can be increased through more vigorous inhalation or exhaling more completely. Okay. And then here's just sort of a graph of kind of that total lung volumes and total lung volumes and capacities. So if you kind of look up here in the right hand of the pictogram, right, it talks about the vital capacity along with that residual volume. So if you have your total lung capacity, that's significant in milliliters, right? So about 6 liters. Okay. That residual is here. We've got that tidal volume, which is kind of that normal in and out, which as you see is still about 500 there. And then that vital capacity, okay, extends to about about 4,800, somewhere in there. So again, or as we move on, I'm sorry. So respiratory physiology, the gas exchange, again, it occurs between blood and the alveolar air across that respiratory membrane, and one of the important aspects of that active inhalation process is that as the thoracic cavity creates more volume, as the lungs expand, those capillaries, they stretch as a balloon, as like a balloon does that you blow into, so they become thinner. And part of the thinning of those capillaries, and as those alveoli expands, it allows for much easier diffusion or efficient diffusion of oxygen and carbon dioxide, oxygen and other wastes to and from not only the respiratory system or that respiratory interchange, but also that cardiac interchange. It's going to depend on the partial pressures of gases involved, and it's the diffusion of that between molecules of a gas and a liquid, right? So again, that expansion or thinning of that capillary membrane makes that diffusion of molecules even easier. Okay, so alveolar air versus atmospheric air. So you got that dead space air, which mixes with that alveolar air. So that dead space is pretty much from the nasopharynx kind of down into the lung fields, and the mixture differs from both atmospheric and alveolar samples. Okay. Partial pressures within the circulatory system is that division of gas exchange. So External respiration is the diffusion of gases between blood and alveolar air, and it's going to occur across that respiratory membrane, while internal respiration is going to be the diffusion of gases between blood and interstitial fluids, and that's going to occur across those endothelial cells of the capillaries. Respiratory physiology. So the partial pressures within the circulatory system, the deoxygenated blood from the pulmonary arteries. Okay, so the lower the partial pressure of oxygen and the higher the partial pressure of carbon dioxide in than alveolar air. So that diffusion between alveolar air and pulmonary capillaries is going to elevate the partial pressure of oxygen, and it's going to lower that partial pressure of carbon dioxide. So continuing with the riveting theme of partial pressures, that partial pressure within the circulatory system, and really with the partial pressures, what we're really dealing with is gradients or movement from greater to lesser, not lesser to greater. So in those pulmonary venules, okay, oxygenated blood reaches equilibrium with alveolar air at a partial pressure of 100 millimeters of mercury for oxygen and 40 millimeters for carbon dioxide. Okay, so this is why we see the movement as you follow here, coming down, right? And so we've got, let me back up. So you see here the partial pressures involved, and then as you got this respiratory membrane here, and then the pressures involved inside the alveolus. Okay, and so as you can see, the movement of these are going in the direction of greater pressure to lesser pressure. Okay. Partial pressures within the circulatory system, again, diffusion, oxygen diffuses out of the capillaries, carbon dioxide diffuses into the capillaries and continues until the partial pressure is the same as the adjacent tissues. So that's why we don't have just one area that's doing rocking good and another adjacent area is not doing as well. Okay. Again, another pictogram of how this whole of how the diffusion of the partial pressures within the circulatory system is working. And then back to, partial pressures within that circulatory system, the blood returns to the alveolar capillaries, and then external respiration replaces oxygen released into tissues, and then excess carbon dioxide is lost. So oxygen to the blood, carbon dioxide eventually moves out to the external environment. When we start talking about the transport of these gases, particularly oxygen and carbon dioxide, plasma, right, which is kind of one component of total blood, is limited solubility for oxygen and carbon dioxide. Can't absorb enough to meet the demands of peripheral tissues, and that's why like straight up plasma is not like the big thing, especially in those folks in shock. Okay. Now red blood cells, on the other hand, they can take up that dissolved oxygen and carbon dioxide, and by dissolved, right, talking about gases into liquid. They bind the oxygen, and they manufacture these soluble compounds with carbon dioxide. Red blood cells reaction is to move dissolved gases from the blood plasma, and these gases continue to diffuse, but they don't ever reach equilibrium, nor do we want them to really reach equilibrium. And fortunately, right, the reactions are only temporary and are completely reversible, so there's this give and take, to and fro, pretty much nonstop, in terms of the respiratory process of of our bodies, right? And so we do know clearly that there's a difference, and I think we all know and agree that there's a difference between respiration and ventilation, right? So ventilation is that mechanical process. Respiration is that actual the utilization or the movement, diffusion of oxygen and carbon dioxide as well as other gases from to the internal environment and from the internal environment to the external environment. Um, High plasma concentrations in terms of gas transport, right? Molecules are removed by those red blood cells, and in those low plasma concentrations, those red blood cells, those RBCs, release stored reserves. The oxygen content of arterial blood is a 1.5% in solution, and the remaining oxygen is bound to the hemoglobin, particularly the iron in the heme units. Okay, again, a lot of this you're like, hey, why do I need to know this? I just need my refresher credit. And I dig it, but we'll continue on. So during those periods of exertion, right, whether it's just a sympathetic nervous response or exercise or whatever, right, which I realize exercise is also part of it, has a sympathetic nervous response. You're going to have that temperature rise, the oxygen, and pH is going to drop. So the oxygen drops, right? We become more acidic, and the hemoglobin reaching the area releases more oxygen, and that released oxygen or extra oxygen or more oxygen is used by the active muscle fibers. So if the hemoglobin doesn't release more oxygen, if it didn't, well then that partial pressure, the oxygen would almost fall off almost immediately, and exertion would come to a halt. So carbon dioxide, right? We've gotten the good stuff in, the oxygen. Now we have to get the byproducts out, and the aerobic metabolism creates this carbon dioxide. It's in the bloodstream. It's going to dissolve in the plasma. It's going to bind to hemoglobin with red blood cells, and it's going to be converted into that carbonic acid molecule. Plasma rapidly becomes saturated, counts for about 7% of carbon dioxide absorbed in the peripheral capillaries, and the remaining carbon dioxide is going to diffuse into red blood cells. Okay. Hemoglobin binding, right? You have to have sufficient hemoglobin. Binds to the globin protein portion of that hemoglobin molecule. Forms that carbaminohemoglobin. It doesn't interfere with the oxygen binding at the heme unit or that iron unit, and it accounts for 23% or so of carbon dioxide in the blood. And so here's this little, again, pictogram or picture or whatever you want to call it. Carbon dioxide diffuses into the bloodstream. So that 7% is going to remain in the plasma. 93% diffuses into the RBCs. So then you see that we've got this this flow of carbon dioxide. It's then going to disassociate, right? And that acid is going to be removed by the buffers, especially. It's going to be moved, right? And it's going to be moved out of that red blood cell, and is going to be exchanged for that chloride ion. So in that carbonic acid formation, carbon dioxide gets converted to carbonic acid, carbonic anhydrase enzyme in red blood cells, and that carbonic acid molecule disassociates almost immediately. So it forms that hydrogen ion and that bicarb ion, and then 70% of that carbon dioxide is transported as bicarbonate, right? So it binds. Okay, and so kind of here we go. right? So we've got that carbon dioxide, excuse me. So we've got carbon dioxide, water, we've got that carbonic acid, and then it's going to disassociate. Okay, it's going to break up into acids in the bicarbonate. So carbonic acid formation reactions occur rapidly. They're completely reversible. Most carbonic acids immediately dissociate, and that intermediate step can be ignored. And so the reaction just kind of does this back and forth, hence the, take you back to high school chemistry, hence this just constant shift to and from, or back and forth, amongst trying to get balance within the system. So reactions proceed from left to right. Carbon dioxide continues to arrive, diffuses out of the interstitial fluids. Hydrogen bicarbonate ions continuously removed. That hydrogen ion binds to the hemoglobin molecules. And that bicarbonate ion diffuses into surrounding plasma, and it's matched by the entirety of the chloride ion. So you get this chloride shift. Okay, carbonic acid gets formed. The venous blood at the alveoli, and the carbon dioxide diffuses out of the plasma. Partial pressure of carbon dioxide declines, and the reaction, reverses. All right. Carbonic acid formation, so the partial pressure or that carbon dioxide declines. Carbon dioxide diffuses out of the red blood cells. The hydrogen ions leave the red blood cells, which is what we wanted to do, and convert into water and carbon dioxide. So real quick, let's check out this video on the control of respiration, and we'll pick back up in just a minute.
Armando Hasudungan, biology and medicine videos. Please make sure to subscribe. Join the forming group for the latest videos. Please visit Facebook, Armando Hasudungan. In this video, we are going to look at control of respiration. Now, the medullary respiratory centers control respiration. The medullary respiratory centers are made up of the ventral and dorsal groups. The ventral group is responsible for the rhythmicity, you can say, of breathing. If that didn't all make sense, let's look at a diagram. So here I'm drawing the brain. If we zoom into the brainstem region here, we can locate where the medulla oblongata is. Here I'm drawing 3 red circles. The 2 red circles here make up the medullary respiratory center, which is made up of the ventral and dorsal respiratory groups. The ventral being the front and the dorsal being the back. The dorsal group is responsible for inspiration, the diaphragm, and the ventral one is responsible for the rhythmicity of breathing. But then you have this other respiratory center located in the pons, known as the pontine respiratory center. The pontine respiratory center will interact with the medulla respiratory center to smooth respiration. It will provide tonic input to the medullary network here to help coordinate smooth respiratory rhythm. So they will send signals to here, and then the medullary respiratory centers will work together, and then will send signals for inspiration and expiration. So to understand how it sends signals for inspiration and expiration, let us look at the thorax. So here I am drawing the thorax, which is made up of the ribs here, as well as the sternum here. Now within the thorax we find the lungs. Beneath the lungs we have an important muscle known as the diaphragm. The diaphragm is one of the important muscles in respiration. And then you have another important muscle in respiration, which are known as the intercostal muscles, which run between the ribs. Here I'm drawing the trachea, which connects the larynx to the lungs. So in a very simplified way, the respiratory center will send impulses to the muscles of the lungs to trigger inspiration or expiration. So for example, here we have impulses being sent via neurons to the intercostal muscles to cause inspiration. So the ribs will rise. And the impulses are also being sent to the diaphragm to cause inspiration. So the diaphragm will descend. The respiratory center will send impulses to cause inspiration and expiration. The quicker the impulse, the faster the breathing. The slower the impulse, the slower the breathing. And that's an important concept to understand. Now, let us see what can influence the respiratory center. And so what can increase respiration, so increase breathing, and what can suppress breathing, so slow down breathing. Firstly, we have the higher centers of the brain, where we can have voluntary control. So as we know, we have some control over our breathing. We can stop breathing for a while before the brain just takes over. The higher centers of the brain are also important for the perception of pain, emotion, and temperature. And so all these factors can influence the respiratory rate. So they will firstly either stimulate or suppress the pontine respiratory center, which then will stimulate or suppress the medullary respiratory center and respiration itself. But the main regulator or influencer of respiration would be the peripheral chemoreceptors, which are located in the carotid and aortic bodies. They detect changes in the blood, chemical changes in the blood. So for example, if they detect a decrease in oxygen, a decrease in blood pH, which means an increase in hydrogen ions, and an increase in CO2, this will stimulate or trigger the chemoreceptors located here in the carotid bodies and aortic bodies, and they will stimulate these chemoreceptors to stimulate the respiratory center. And so when the respiratory center is stimulated, there'll be a quicker respiratory rate. So you will breathe in and breathe out quicker. And so you can breathe in more oxygen and you can breathe out more carbon dioxide to neutralize everything. There are also chemoreceptors located in the medulla known as central chemoreceptors. The medullary chemoreceptors do exactly the same thing. They can detect changes in pH. A decrease in pH, for example, and an increase in CO2 will stimulate the chemoreceptors to stimulate the respiratory center so that you could breathe faster, and thereby breathing out more carbon dioxide and inhaling more oxygen. You also have receptors in your muscles and in your joints, and these will be stimulated when you exercise. And so when you exercise, these receptors will stimulate the respiratory center so you can breathe quicker. And it's important to breathe quicker when you exercise so you can breathe, so that you can take in more oxygen and you can blow out all the acid that has built up. And finally, you have things in your lungs that can regulate the respiratory center, that can influence the respiratory center in the brainstem. Firstly, you have things called irritant receptors, which are receptors that are protective in the lungs that help essentially blow off the irritant. And so when they're stimulated, they will suppress the respiratory center to slow down respiration. And then you have stretch receptors in the lungs, which cause the hearing breather reflex, a reflex that is protective. It's a protective reflex initiated by extreme overinflation of the lungs. And so when these stretch receptors are initiated, they will suppress respiration. So they will slow down the respiratory rate. Hope you enjoyed this video. Thanks for watching.
All right, so we're picking up a little bit. We're going to talk just a little bit about hypoxic drive after we just watched the video or that presentation. I really dig that guy's drawing, so that's part of the reasons we do it. So hypoxic drive, right? So hypoxic drive is going to be that patient that's different than what most of us normally breathe with, right? These are the ones where you would assume they are the ones walking around their house, quarter mile worth of nasal cannula tubing, smoking cigarette, the whole 9 yards. But really, we don't really know whether or not just by looking at a patient whether or not they're hypoxically driven. We can guess, but we're not exactly sure. It's more of a blood test deal. So anyway, so hypoxic drive, instead of feeling or detecting the acidity, we're going to talk the body, the baroreceptors of the body are going to detect the partial pressure of oxygen in the arterial blood, basically due to the chemoreceptors being accustomed to high levels of carbon dioxide. It's typically seen in patients with COPD, but you can't, just because someone says they have COPD, doesn't really mean that they have, or they're hypoxically driven. Okay, it's a good indication though. And the body again tends to adapt pretty quick, and like I just stated, right, as the partial pressure falls. Actually, I didn't state this, but as the oxygen or the partial pressure of oxygen falls, respiratory stim occurs, and then as it rises, stimulation is inhibited. And this is why a lot of folks will kind of freak out when you put them on high flow oxygen, right, that non-rebreather at 15 liters per minute, and someone's like, oh, you're going to knock out their respiratory drive. It's kind of unlikely, especially in those short transports that most of you guys or most folks transporting from home to hospital are going to encounter. For some that are in the outlying areas and you have maybe an hour transport time, it's possible, but a lot of times those are going to be interfacility transports, and you'll just be continuing whatever treatments have been given on the upfront. If you're in that situation where you are doing that long sort of BLS or facility to facility transport, and you suspect that maybe your patient's not receiving the oxygen the oxygen supplementation that they should be, of course, always question, and you defer to that medical control. Okay, so what is adequate respiration, or what rate are we looking at, or what are we looking at when we talk about adequate respiration? So the cells require a supply of oxygen for metabolism and a way to dispose of the waste products, right? We just spent 50 slides going through that. So respiration has to be sufficient to support life, and it's the process of moving oxygen into red blood cells and tissues and metabolizing oxygen to make ATP, or adenosine triphosphate. So think about metabolism as that chemical reaction that takes place within an organism to maintain life. Okay, so respiration provides both. So without oxygen, the body cannot efficiently produce energy. Okay, metabolism is aerobic, and without that oxygen, it becomes anaerobic, which is a pretty inefficient way of utilizing glucose, or utilizing glucose to produce energy. So lack of oxygen leads to cell death, right? Cell death to tissue death to organ death to organ system death, and then once the organ system dies, the organism starts to die, and once the organism dies, well, then they're dead, right? So it's important for us to know, right, that the brain and the nervous system can die without oxygen for 4 to 6 minutes. And you must have a way for oxygen to travel through the body. So CPR is that mechanical means, right? We're not necessarily, I mean, we'd like for the heart to pump on its own, but one of the big reasons we're doing the old CPR is to perfuse the brain, or to allow brain tissue and the nervous system to get oxygen sufficient to at the least try to prevent further damage. Okay, the kidneys will die within 45 minutes without oxygen. And we'll just transition now into the respiratory system. So when we're assessing the respiratory system, right, that primary assessment is always going to be A, B, C, right? So airway, breathing, and circulation. Is the airway patent? How are they breathing? What's their circulation? And the exception to this, though, in that primary assessment is in cardiac arrest. They've kind of flipped it from ABC to CAB, right? So you want circulation, airway, and breathing, and remember the goal on that is to get pumping as quickly and efficiently as possible in an effort to, because there is a lot of oxygen still attached to red blood cells and hemoglobin, that it can still support life even in the absence of artificial ventilation. So anyway, that's why that's what the most recent studies have shown. And so just remember that as you're in your own clinical practice. So airway, right? Is it patient? Is it patent, right? So patent is just open and clear, right? And is the breathing adequate in terms of effort, the tidal volume? Are they taking in enough in that respiratory cycle to sustain life? Is the rhythm, and again, is it regular or irregular? Do we have good chest movement? Is it symmetrical? Do we have good chest rise and fall? And do we have full excursion? And then if we've got that fifth vital sign working, right, we're going to check and see if pulse oximetry is in that 96 to 99%, even on just room air. Okay. So just a couple of pulse oximetry interpretations, right? So 90 to 95 to 100 is going to be normal. 91 to 94 is mild hypoxemia. Moderate hypoxemia is going to be 86 to 90, and then severe is 85 or less, right? So the big deal on all those, right, is if we look at the intervention, basically if it's not in that normal, which we want to maintain, we're going to have to increase that oxygen saturation, again, going from least invasive to most. But at that 91 to 94, it may be a nasal cannula, maybe a non-rebreather, maybe it's a CPAP, right? But in that 86 to 90, maybe we have to get a little bit more proactive. We have to get more aggressive, and possibly creating or assisting with mechanical ventilation, again, either through CPAP, or for us, pre-hospital, most commonly would be like a bag valve mask or intubation with a bag, or with an ambu bag. Continuing on with respiratory system assessment, capnography. So you want to, it's that recording or display of exhaled carbon dioxide levels measured by capnometry. And so end-tidal CO2 has become the gold standard. And what you'll find is with end-tidal CO2, right, which is at the conclusion of this lecture, but in this module, you'll find 3 fairly short videos that go pretty well in depth for what the pre-hospital provider needs to know in terms of utilization of end-tidal CO2. And using it and taking the metrics to improve patient outcomes. Okay. In that respiratory system assessment continued, right? So carbon dioxide is the normal end byproduct of metabolism. Can be detected by using colorimetric or an infrared device. The problem with some of the colorimetric devices is, particularly in cardiac arrest, is that they're only reliable for about 5 minutes, right? And then after that, they become unreliable. And since we are using more advanced methodology, or we have the ability to use more advanced methods, end-tidal CO2 is going to be the device of choice. And remember that end-tidal CO2 can not only be attached to the end of your ET tube, but can also be attached to the end of a King LT, the working lumen of a combi tube, the working end of an LMA or an iGel. So it's not just for endotracheal intubation or ET tubes, okay, but is an extremely useful resource. So typically when we start talking about where we want to see capnography, or where we want to see that patient hanging out in terms of partial pressures, typically we say 35 to 45. And what you'll see, or as you see on this graph, is arterially, or that arterial CO2 is going to be 35 to 45, with end-tidal CO2 capnography at 30 to 43. So anywhere kind of in between there, right? So we'll take somewhere between 30 to 45. Ideally, that sweet spot is going to be kind of 35 to 43-ish. But again, anywhere in that range is what we're shooting for, okay? That keeps us in a nice, even keel. Basic rules of capnography. And these are super important, right? You got the sudden drop to zero. You've got to start using, one of the things we'll talk about as we start talking about airway management is the use of the mnemonic DOPE, right? So flashback to either 2 years ago when you took the refresher or paramedic school, right? So DOPE is displacement, right? So you've got displacement, obstruction, pneumothoraces, and equipment failure, right? And so pretty much this here will manage most of what this is talking about, with the exception of kind of this one here. And so again, when we're talking about those rules of capnography, okay, let's go back again. Oops. So you got that sudden drop, esophageal intubation. And one of the things you'll see on one of the videos we'll post in the management is the actual attachment, or one of the things discussed is the actual attachment of the end-tidal CO2 to the tube, even prior to insertion, right? Like you've got everything ready to go, and you just use it as a way to very quickly identify whether or not you've placed the tube in the right opening, right, in the trachea. So yeah, again, take a look at this table 5.5. It's from Paramedic Care, the 4th edition, which is most of what this lecture has been based on out of that book, with a few other resources. And again, a couple other reasons, and so we'll just take a second to look at these. And again, the videos that have been provided, it's parts 2, 3, and 4. It's located kind of at the bottom of the module as you look at as you're looking at the refresher class under Airway. Those are going to give you really good ideas about the utilization and how to use end-tidal CO2 to your best advantage and to your patient's better outcome, hopefully. So again, respiratory system assessment, right? We're going to the electronic, they can be qualitative or quantitative, reading monitored in patients who are not intubated and who are intubated. So you can put in the what looks like a nasal cannula prong and actually get a continuous waveform capnography readout for patients that are not intubated, that you're treating through other modalities. Comparisons of mainstream and side stream capnography. So like in that mainstream, it's that sensors between the ET tube and the breathing circuit, right? So you've got the ET tube, your carbon dioxide sensor or CO2, and then you've got the ambu bag or the another breathing circuit. And then on that side stream, it's going to be aspirated from a sampling tube and analyzed away from the patient. What we typically see is going to be that mainstream capnography. It's especially as in our typical practice, some critical care medics out there, you may mess around with some side stream capnography, but I'm not really aware of anybody using it currently in this area. Okay, so here is that example, right? You've got your tube. You've got your tube. You've got that detection device, and then you've got the breathing circuit. All right, so continuing on, that capnogram reflects exhaled CO2, concentrations over time, and the 4 phases. And again, I'm not going to spend any time talking about the 4 phases here, as they are covered very well in the videos that have been attached to this module. Okay, some medical conditions, right? Obstructive disease, rebreathing, curare cleft, the esophageal intubation, and the endotracheal tube or circuit leak, right? So these can reflect some abnormalities that arise. Okay, some medical conditions, right? That ventilation, perfusion mismatch, apnea, hyperventilation, hypoventilation, and then using CO2 detection is useful in the effectiveness of your CPR. Okay, so it's not just whether or not you got your tube in, but really how effective is your CPR, are your compressions, and your whole system working in hopefully reviving that patient or in providing treatment to that patient. So we've got that patent airway. If it's not patent, right, we're going to make it patent. And again, we're going to speak a little bit more to this in the airway management portion. Adequate breathing, right, for rate, it's going to be 12 to 20 for adults, 15 to 30 for for children, and infants is going to be 25 to 50. And that's always relative to the level of activity the patient is engaged in and their level of physical fitness, right? So Johnny smokes 2 packs, may have a rather different resting ventilatory rate than, Jane runs a lot and is in great physical shape. So adequate breathing, right? We want to check quality. Breath sounds, if possible, that posterior approach or that posterior aspect gives you 10 really good listens. But most of us are going to do the anterior approach, so just be sure you're getting a good listen at the apices, right? So around the clavicles, then kind of mid-axillary, and then low in the lobes. Chest expansion is symmetrical. We have good chest rise and fall. And you may find that the breath sounds up at the apices or the apexes are not as audible as the bases. And that's due a lot of times to the apices filling up first, right? So we're going kind of down that pressure gradient. Inhalation is usually more audible than exhalation because of the duration of inhalation. And because during exhalation, a lot of times the airflow rate is longer in duration. Okay, so same, good quantity of air, just a little bit longer. Okay. So this results from inadequate gas exchange. If the patient is having difficulty breathing, right, you got to ask them, because if you don't ask them, they may not appear to you be having difficulty, but they may be kind of suffering in silence. Okay. First response to inadequate gas exchange is that respiratory rate, depth, and quality is going to increase. Respiratory or that mental status or mentation starts to change, and then signs and symptoms may be subtle in terms of what is going on. It may be sudden onset, so very acute, or may take a bit. Okay, and then there's hypoxia, right? Tissues and cells don't have enough oxygen, so you may have that cardiac ischemia, pulmonary edema. It could be caused from an overdose or CVA, shock, any variety of shock, and COPD. Dyspnea, right? Difficulty breathing. Tidal volume may not be enough. So you got respiratory distress. That's going to be an increase or a decrease in that rate. So what may happen is that tidal volume may not be enough. That dead space volume in the lungs contains air that is inhaled but doesn't really reach the alveoli, and because of that, includes both the upper and lower airway, and that's usually about 150 milliliters, and so you may even have some air trapping that occurs. Kind of one of those others. That was sort of a side note, I guess, or I don't know, kind of a blathering of other stuff. So anyway, back to respiratory distress. So you have an increase or a decrease in respiratory rate, right? The accessory muscle use, neck, abdomen, intercostal, so on and so forth, secondary to the diaphragm. Okay. That decrease in tidal volume, sometimes they're just not overcoming some dead space issues. And then, that skin's going to start showing the signs of not being properly oxygenated, right? Because we're going to shunt the core in an effort to maintain the vitals. All right, so again, respiratory distress, the rate can increase or decrease, depth can decrease, maybe even increase, right? Chest expansion could be minimal, could be unequal or paradoxical. The rhythm could be regular or irregular, and in that rhythm, right, it may or may not be. It may be respiratory distress, which may be secondary to another event, and examples of that irregular rhythm is the neurologically based abnormalities or respiratory rate abnormalities or rhythm abnormalities, right? Your Cheyne-Stokes, your biots, your neurogenic hyperventilation, so on and so forth. But one of the indications, right, of that hypoxia, especially that's not related to the actual respiratory system in itself, is that heart rate. If you've got a heart rate clipping at 130 or greater, that's a really good indication of severe distress, and most likely there's hypoxia going on. We want to get good quality of breath sounds, right? So wheezes, crowing, stridor, snoring, and gurgling are all upper airway issues, okay? For a variety of, wheezing is not. Wheezing is a lower airway or abnormality or obstruction, okay? But crowing, stridor, snoring, and gurgling are all upper airway issues. Wheezes, rales, and rhonchi are lower airway issues, okay? And then agonal respiration is that overall respiratory issue, right? It's that occasional gasping breath, that death rattle, that, hey, I just heard my grandma breathing. Well, no, it's that occasional gasping breath. And then there's apnea, right? That's that complete lack of breathing. So folks, as you well know, may progress quickly from distress to failure, or may just go straight into failure. And that it becomes worse as the brain and vital organs can no longer compensate for that impaired gas exchange. In managing that airway, and we're going to hit on this even more in the managing airway portion of the course, if that patient's laying down or on their side, are they breathing adequately? A lot of times we can base that on, MOI, mechanism of injury, or NOI, Is there potential for spinal injury? If yes, we're going to do that modified jaw thrust. If no, suspected spinal injury, just good old-fashioned head tilt chin lift, using proper head tilt chin lift, not grab the back of the neck and crank their head up so that their occiput kind of moves down towards the shoulders. All right, and then airway problems, right? So facial trauma, particularly if we have to provide ventilatory support using basic means. So, someone has that Lafort 1, 2, 3 sort of fracturing, that can be problematic. Jaw bones that are missing, dentures and other dental appliances, even partial dentures, right? That can be a true airway obstruction. Foreign bodies, including dentures, but also gum, food, and smokeless tobacco. Secretions, right? There's nothing like good secretions to muck up your day in terms of managing an airway. So blood, saliva, and mucus, particularly what we run into, right, that becomes extremely problematic is going to be more of that blood, potentially saliva, but mucosa or mucus, not typically. And then finally, right, we want to be extremely aggressive with suctioning. There's nothing wrong with allowing a conscious patient to suction themselves, right? Especially if they're conscious alert oriented. Maybe they just got significant facial trauma. They're able to maintain their own airway, but we want to make sure that they're clearing their airway with minimal effort. And so possibly, just giving them that Yonkers and just giving them quick instructions on how to take care of that will solve a potential airway problem that you may have to manage. If the patient's gurgling, right, this is all kind of no-brainer stuff, and you guys are well adept at managing this situation. If they're gurgling, if there's visible fluid, or if they have that accidental inhalation of fluid or particles into the lower airway, right, that aspiration, that's something we definitely want to get ahead of. So if we see gurgling and visible fluids, we want to get ahead of, get suctioning, get ahead of that potential for aspiration, and hopefully just through that aggressive management of that small window of just fluids in the oropharynx, we can help them a little bit later on down the line in terms of survivability. Okay, so that was the down and dirty, maybe longer than you wanted to deal with, airway and respiratory anatomy. A lot of it maybe got a little muddled in that partial pressure stuff. Please feel free to hit me up via email or through some of the class means, so discussion boards, so on and so forth, and I'll be more than happy to answer any questions you may have. All right, until next time, which will be the next time you press the next lecture, have a good one, and thank you very much.